Okay, hi, this is Elliot Fishman, and welcome to Facebook Live. And quite a day here. I was actually I'm home because I have to finish my Rankin-Ray exhibits, and I had like 1,000 phone calls today, which go on and on and on. So basically, what I tried doing is working from home, and then a few minutes ago, all the power went out in the house. Now, hopefully this thing says live, and hopefully it is live. Well, so we'll see. Here we go. And hopefully you guys can see me. Okay, so it's great. It's great to be here, and I hope everyone's doing well. I think we all survived the elections. I mean, maybe except for one guy who lives in Pennsylvania Avenue, maybe he's not as happy as he could have been. But I think hopefully they'll finish the counting. I've heard they are bringing in the count from Sesame Street to help out because nobody can count to 10 better than that guy can, and maybe 20, even 100. So I think they want a legitimate count, and we all know that if you can't trust the folks from Sesame Street, you really can't trust anybody. So probably the things will go well. It's interesting, the stock market, which everyone said would go down if Trump lost or Biden won, depending how you look at things, seems to be going up at least for 2 days, in part because the Republicans held on to the Senate, and the logic is nobody loves something more than a balance of power rather than everybody just streamlining in. So hopefully things will be straightened out, and things are quiet in the country. So that's a good thing. And hopefully whoever wins will be a great 4 years, and we'll be able to do all the things we need to do. Uh, and hopefully, most importantly, this current president will be the one, hopefully, in 4 years when they run for re-election, can say, I was the one who ended COVID. So hopefully they could say they did that early in his term, and that the prior president can take credit, that everybody can take credit, because I think all of us are the same. No one cares who takes credit for curing COVID. No one cares if it's Pfizer or J&J and AstraZeneca or Moderna or any other company. We just care that we can get back to normal and go out to Panero's and get a tuna fish salad and a cup of coffee without feeling like you're risking your life. So hopefully next week, I think I'm told, and it's open to a little bit of discussion, Pfizer will be reporting their results of their vaccine. And the good news is we'll see how good it is, and that's really the question. But remember, Pfizer is the only company that has not had to stop their trial at any point. And the trial stoppage is usually due to a patient reaction or a patient having some type of unexpected event. So the fact that nothing's happened like that, now it's only 40,000 people and half of them are not getting the vaccine, but let's say it's 20,000. That's a small number, but that's good news as opposed to someone having some issues. So that part's really good. Now, of course, you want to make sure the vaccine works. Simply not causing reactions is great, but unless it works really well, it's not going to really help anybody. So hopefully that will be helpful. I am getting my hair cut on Saturday. I just washed my hair, you can see, but it's like super long. This is like Woodstock long. Actually, at Woodstock I had really short hair, but this is more like college, college, end of college. I think I'll get a haircut at the end when I went to the Catskills, and they wouldn't let you work in long hair, so I had to cut my hair back so it would. Some of the guys used to get wigs, but I wouldn't wear a wig. I just cut my hair back. So this week, what else? I want to thank everyone for their kind comments. That our team won the Ann Mini for the best app. So that's 3 of the last 4 years, and 4 of the 8 years I'm told that Ann Mini exists, and that's our 12th Ann Mini. So that's pretty good, and we are working really, really hard on updating or developing new apps so we can win again next year. I think having won, that's old news. That was last week. Now the question is, what about 2021? So we are working, and we're going to work really hard developing new apps for that as well. We're also putting a lot of new things, as you see, on CTisus. A lot of content. Lily and Sarah have been updating things, updating a lot of the lectures. We have a lot of new lectures that I've recorded already. That are not just updates of, let's say, pancreas or liver or kidneys. A lot of very focused updates. I just did today, actually, I finished on extramedullary hematopoiesis and thalassemia, which is a good differential diagnosis. We did renal arteries and all the things relating to the renal arteries that we prepared for RSNA. And the thalassemia extramedullary hematopoiesis was prepared for the Roentgen ray, which is next May. And then also, what else did I do? I did something else which I can't remember, but we're working on that. There'll be some stuff on spleen. We've redone some new stuff on the spleen lately. So we have a bunch of different things I think that are coming along that hopefully I think you're going to enjoy. So the topic today was on cinematic rendering, and in fact that's the topic that's also on the Roentgen ray, cinematic rendering of lower extremity trauma. So we do see, even in the face of COVID, we do see lots of trauma for the lower extremity. Our main indications for lower extremity trauma are MVAs, right? Patients are either passengers in the car or passengers or people on the street that are hit by a car, or gunshot wounds. Sometimes there's stab wounds, but in Baltimore, there must be a shortage of knives, but there's no shortage of guns, so we see a lot of gunshot wounds. So really, if you think about it, so when I talk about the lower extremity, we'll talk about from the pelvis, but not worry about the pelvis. We'll talk about the femur, tibia, fibula, downward. And so you talk about trauma, again, one of the main applications of 3D imaging in the beginning was bony trauma, right? Because remember, it took a long time to scan. Our first papers were on acetabular trauma, as were many people's papers. We expanded to pelvic trauma. Remember hip graphics, hips. We got a lot of hips. We got a lot of pelvises. But now we talk about lower extremity trauma, so we'll talk about 3 things you look at. So one, and we'll talk about from the outside in and why cinematic rendering will work so well. You want to look at the skin and the soft tissues. Sometimes you can see the bullet entry and exit wound. Sometimes you can see a stab wound. You can look at the skin and soft tissues, obviously, for fractures, if they're open fractures or not. And that shows very well on cinematic rendering. And in cinematic rendering, as well as volume rendering, truthfully, you can get a really good look at the soft tissues and muscle. So you can see where the entry and exit wounds are. So that works out very, very well. We then want to look at the vessels, because obviously with any of these injuries, you can get vascular injury. And vascular injury can be anywhere from active bleeding, could be with maybe an AV fistula, particularly with penetrating injuries. It could be vessel occlusion due to thrombus, the trauma. It could be spasm of the vessel, just local injury and spasm for the vessel is narrowed. Sometimes you don't even see any flow at all, but at surgery it'll look normal, but and you look for proximal and distal appearances of the vessel. So that's another thing. We then also look at the bony structures. Is there a fracture to the bone? And more importantly, particularly in complex injuries, what's the extent of fracture? Does it need to be operated on now, or can it wait? Are you going to replace it, fix with a plate or with a screw, or can you just manage the patient conservatively? There's a lot of different options in that regard. So how do we do it? Well, the best way to do it is with IV contrast. You must use IV contrast. IV contrast, obviously, you can't see vessel injury without IV contrast. Yes, you can see a big hematoma. You don't need contrast for that. But you want to know what the vessels look like, particularly on the arterial side. Sometimes you need to do dual phase because you want to look at venous phase as well. One of the things, of course, when you do classic CTA, you're looking only at the arteries. When you start seeing veins filling, assuming you're not too late in your acquisition, when you see veins filling, what you really are seeing is early AV shunting, which can be due to an AV fistula, or just can be due to the trauma with hyperemia, and you see faster vessel flow. So you want to look at that. Now, because we want to look at vessels when we do the reconstructions, we want to make sure we're using thin sections. So we use 0.75 thick sections every 0.5 millimeters. Timing, you want to be in arterial phase. It's always tricky doing lower extremities. We know that. Most of the time when we do trauma, or a lot of the time, it's pan scans, chest, abdomen, pelvis. People who get shot in multiple areas. And so arterial phase, you'll do a good job, 30-second delay up high. You'll do well in the chest, the abdomen, and the lower extremities. If I'm only doing the lower extremities, then I would probably either do a triggering at about 250 off the level of the aortic bifurcation, or wait probably 40 seconds. I think when you're doing lower extremities, the biggest danger is being too early, particularly when you look not so much at the superficial femoral or even the popliteal arteries, but when you're looking at the trifurcation vessels, if you're too early, you're just not going to be able to see it, okay? Because you're just, Then you might call vessel no flow, but it's really simply just a timing issue. And then, of course, the third thing you look at is bone. You want to look at the presence of fracture, which you can see on CT well, but then particularly in complicated injuries, fracture dislocation, really comminuted fractures, particularly with gunshot wounds. You want to look for displacement, orientation of fragments, the presence and location of foreign bodies, like from gunshot wounds and the like. CT is really good, we know that, for doing that. Fritz and I and Efron wrote a paper a number of years ago showing the value in lower extremity trauma. Of course, cinematic, what it does is it takes it one step further. Now, surely you need to have 3D imaging to really look at the vessels well. And to say a patient has a femur fracture or a tibia or fibula fracture, probably you don't need 3D imaging because you can tell that on the axial imaging, and probably you can tell that just looking at the patient. But where the 3D comes in really well is when you're trying to define the extent of injury, the orientation of the fractures, and then what you need to do about it. And so for surgical planning, rod, screw, plates, what do you need to do? Approach, lateral, posterior, anterior. Very, very, very helpful having the 3D imaging in that regard. Now, the other thing, of course, is in terms of reconstruction algorithms. I still like the soft tissue algorithm to use. The soft tissue algorithm, when you're doing any type of 3D work, is ideal for looking at bone, muscle, soft tissue, and vessels. If you only want to look at bone, then a high-res kernel, particularly for small parts like the feet, the carpal bones in the wrist, the tarsal bones in the foot, then of course the high spatial resolution can be very valuable, but I still like to do the reconstructions off the standard. I think one of the challenges with reconstruction off the noisier images with different kernels is that the images are very noisy. I think this way the images are not noisy. It works out very, very nicely. So that indeed becomes very, very important when you look at things. Now, in terms of tricks of the trade, we have a number of presets. So I have this really good preset for looking at the skin and soft tissues. Linda Chu wrote an article last year talking about presets for skin and soft tissue and looking at muscle. So I'll do that and I'll get the images. I'll create a bunch of images. I'll then change the transparency so I can look at the vessels. Now, often with looking at the vessels, you'll want to do bone removal. I think we always do bone removal because with bone removal, particularly from dual energy data sets, it's really easy to isolate the vessel and not have any overlying and perhaps make the images a bit less diagnostic than they could be. So that indeed becomes very, very important to do. So bone removal is critical, and then I'll create images with bone removal showing the vessels only. I also will show images with not only just bone removal, but I'll put the bone in, maybe color the bone, and then show the vessels. So for the surgeon, they'd like to see the relationship of the fracture, let's say the fracture fragments, and the vessel. Maybe it's pushed but not involved. So isolating the vessels is good, but I think also I like to show the bony injury, which we isolate as well, but also show the bony injury with the vascular injury, put everything together. And it's kind of a very elegant type display. You can change the transparency on the fly, and that works very well. Now, it's about 13 minutes in, so I want to tell people, the only person who's signed in so far today, we got a bunch of people I see live, but there's John Biacchino, who's home today. John, I think, is home on Thursday in Owings Mills or Timonium, which is not all that far from here, 10 or 15 minutes. John's one of our great techs. But if you have any questions, it's a good time to ask. Now, in terms of rendering, the question might be, how much better is cinematic than classic volume? I think from a diagnostic perspective, not substantially different, though I think on the skin soft tissue interface, I can do it better with cinematic. And I think you can get a little better display perhaps with some of the vessels with the cinematic as it relates to bone. Both of them work really well. I also will use MIP imaging. When you want to look at vessels, MIP works very well. Everyone has MIP. But remember, with MIP, you need to take the bone away. Now, it can be challenging if you have a gunshot wound with lots of fragments of bone. It can be challenging to separate the bullet fragments from the bone fragments from the vessels. And the computer often takes away too much information. So one word of caution I'll give you is that if you're doing bone removal or you're not doing bone removal, if you're looking at vessels or anything, be very careful when there's lots of fragments around. bone removal can remove important information. You want to make sure bone removal also doesn't remove vessels. Remember, vessels are kind of high density, so is bone, but the computer usually is good at separating the bone from the vessels, but in the presence of a lot of fragments of bone, in the presence of metal from the gunshot wound, the computers tend to either remove too much or remove too little. Typically, it does both. It removes too little, but then it removes too much at the same time. So we always speak about that, about looking at the data sets to make certain that you're not letting the computer make a mistake. We've showed that in some of our lectures, but you need to be very careful in the trauma setting as well. Now, from a technologist perspective, the things we mentioned about timing is critical. Also, it's very important for the patient to be lying comfortably. I know we try to get people to be perfectly straight. Sometimes for the obvious reasons they can't. The most important thing to me is I can create the images in any planar perspective. I can get any view I want as long as the patient doesn't move. If the patient's in pain because you're positioning them, that's a bad sign because they're not going to stay in that position. So get the patient comfortable, whatever that position is. As long as they don't move, the computer can create images which straighten everything out. So that indeed works very well. As I mentioned, I will have a very specific talk on this topic. I am recording it today, but it probably will not be up till, it's not going to be up till the middle of December. That's when it's scheduled, but I think that'll be very helpful to you, showing you very nice examples and where the challenges are, particularly with gunshot wounds, and some of the advantages and how you can easily implement this into your own clinical practice. So let's see, if you have any questions, this would be the time. This looks like one of those audiences where don't ask a lot of questions. I will also say that this is the International Day of Radiology is on Sunday, I believe Lily told me. So we will have something on Monday, a special lecture, a special CTisus lecture on something that relates to that topic. So with that, I guess hopefully I've covered the topic. Have any questions, let me know. I know no one has any questions right now. So anyway, have a great day, and I'll see you next time. Bye-bye.